Isaac Alatise, who is this year's speaker. Isaac's an old friend of ours and a particularly close friend of Dr. Kingham. He is a professor of surgery at the Faculty of Clinical Sciences, the College of Health Sciences at Obafemi Awolowo University. I hope I pronounced that correctly. His area of interest is in surgical oncology, gastroenterology. He did additional training fellowships in endoscopy and colorectal surgery, sponsored by the World Gastroenterology Organization, the African Middle East Association of Gastroenterology and Endoscopy, and the International Council of Coloproctology. He's a real leader and a mentor and trainer in surgical oncology and gastroenterology in his country, Nigeria. And it's safe to say a towering figure as well in the entire region of Africa. He's the Secretary General of the Society of Gastroenterology and Hepatology in Nigeria, and the Nigerian chapter of the IHPBA, Vice President of the West African chapter of Aortic, and a member of the American Society of Clinical Oncology, the African Regional Council. He co-founded the African Research Group for Oncology, otherwise known as ARGO, which many of you would probably have heard about. And through his work with ARGO, he is a co-principal investigator on a number of high-profile NIH-sponsored grants, including R01 and a UH3, as well as a D43 NIH grant. In 2016, he was selected as one of the 50 for 50 up-and-coming global cancer leaders by the International Agency for Research on Cancer. And he, over the years, has trained 30 general surgeons in his country, many of whom are surgical oncology focused, and many of them have taken on faculty positions in Nigeria as well. It's an honor to have you here. Thank you so much for making the trip.
Thank you, Dr. Janigan, for that kind introduction. And I want to thank the organizers of this program for this kind invitation to give this talk that I've titled Starting HPV Program from Scratch, Closing the Gap in West Africa. I have no conflict of interest, and I will be following this outline as I deliver the talk. I'll give a brief about West Africa. West African countries is about 16th in numbers, and it's occupied by half a billion people. And half of those people actually reside in my country, Nigeria. When you look at the public health funding, it's quite low, and it's far low compared to the target that has been set. I practice in Nigeria, in southwest of Nigeria. I actually practice in Ile-Ife, which is about 2 hours drive from Lagos. And my university is Obafemi Awolowo University. You can see the area view of the university. We pride ourselves to have the African most beautiful campus. You won't believe it until you visit our institution. And I dare you to try that. You will agree with us. That is actually one of the best universities in the world. We have about 32 students in the university, about 19 research centers, and almost about close to 100 departments. It was founded in 1962. The hospital that I also work, which is adjunct to the university, was established much later in 1975. The bed numbers have improved from less than about 500 to 832. And we have 2 dedicated surgical oncology units with special interest in HPV. And our catchment area is actually the whole country. So when you're talking about a unit, 2 units dealing with 220 million, you can imagine the volume of the cases that we see. The hospital is uniquely established to have a number of international collaborations. Cardiac program is the biggest in the whole West African country, with the partner from Europe, from Israel, from Egypt and from other countries. And we've also established, like Dr. Janigan said, established African Research Group for Oncology, which is a conglomeration of a number of centers, started with MSKCC and my institution, but there are a number of North American centers that have joined the group, and a number of African institutions that is also working with us. I'm one of the very lucky few from West Africa that met with Dr. Blumgart when he was still alive. And that was when I was doing my surgical fellowship, SODAVA fellowship at Memorial Sloan Kettering Cancer Center in 2009. Then he has stopped his clinical work, but he was still teaching international fellows using videos. And that was how I met him. It was quite intriguing, and he laid an indelible mark on his career grow to change the world of HPV. And that was quite impactful. And that has actually left an indelible mark on my career. He was so passionate in delivering and transferring knowledge to others. And this he does with a great sense of humor. He was a pioneer. He pioneered HPV surgery with a few colleagues that started the program in those days. And he actually helped to build ERCP program in the early days. He was so passionate. And one thing that characterized him is that he's a researcher par excellence. By the time I met him, that was the first time I would be seeing somebody that have published over 500 manuscripts. And I was wondering, how was this done? But of course, I know that this is very possible in your life career. By the time he died, he has published close to 1,000 manuscripts, definitely. He has published about 100 books. I couldn't imagine how you still sleep and manage your family and still do such a lot of work. But that's the kind of a person that we are talking about. He knows the trade and he knows it very well. He knows how to operate, when to operate, and when not to operate. He was one of those people that introduced adjunctive therapy in the management of HPV cancers. And one thing that stands out about him is his sense of humor, especially when you have complications. We are surgeons in the house. You know that if you don't have complications, it shows that you've not done enough. And one of the common quotes of him is that when you have a biliary fistula and your resident called you that you should come and do something, make sure you sack the fellow and still wait. So he's a man of humor and a man to be envied indeed. One of the things that stand out is the burden of HPV cases in Africa. And that's, I'll quickly, with a few slides, give you a picture of what it is like currently. Unfortunately, we don't have a reliable data, and it's quite difficult to establish, to have a data that projects the number of cases that we have, because we have limited radiology facility, we have limited IR that will take biopsy. Currently, most of the database depend on histopathology, which is not very much available in our setting. The healthcare system is out of pocket. Majority of the people living in the village that cannot afford the treatment, of course, only use the surrogate to be able to estimate what is the burden of the disease we are talking about. I decided to use the hepatitis B virus prevalent as a surrogate to give you an idea of the kind of burden that we are talking about. West African country has one of the highest prevalence of hepatitis B virus. It is said, and if you are talking about Nigerian population of 220 million, that means we are talking about 20 million people are infected. And if you want to use a model estimate of the number of them that will develop HCC, and you use about 2%, so we are talking about close to 500,000 people will develop HCC in the next 5 years. The sad thing is that majority of the people, if not all of them that develop this disease, will actually died of the disease. And the reason is because the workforce to manage this disease is very limited. So what's the current HPV workforce in West Africa? We don't have a dedicated HPV training fellowship in West Africa. The main training fellowship in West Africa is West Africa College of Surgeons. They only train general surgeons, and most general surgeons have not HPV cases. The only few HPV cases that they do is cholecystectomy and surgical bypass, because majority of our HPV cases present with obstructive jaundice. And few of those patients that they can't do surgical bypass are actually left to die until recently. Liver surgery is something that you don't go close because of fear of bleeding. My first exposure about liver surgery, when I wanted to do take a biopsy from liver when I was a senior registrar in my unit. My professor told me, you can do anything in the abdomen, but please don't touch liver and pancreas. That was the mindset I had before I came to Memorial Sloan Kettering Cancer Center. When I saw people touching the organs that I've been told not to touch, it was so intriguing, and that developed a lot of curiosity within me. So practically, most general surgeons in Africa run away from liver, from pancreas, and all those areas. So most of the patients that have the care until recently only visit, travel abroad, or die with the disease, which is quite very sad. I put these slides to show you that majority of our patients actually present very late. Actually, if you think about that, you think probably the whole fault is on the patient because they are not coming to the hospital. All the HPV cases that we've seen, which is about 500 cases, we noticed that majority of them have actually been seeking for help. Majority of them have visited 2, 3, 4 hospitals before eventually coming to receive treatment. The patient that they are presenting very late, but because the system is not very strong enough to be able to support their treatment. So we did a survey looking at what is the HPV workforce capacity in West Africa. We used the surgeon oversee questionnaire that was distributed after a regional meeting to all general surgeons in West Africa. Every country was contacted so that they can provide the idea of the number of. The instruments has 5 domains, and all the general surgeons were actually contacted. Not all the country responded for obvious reason. In most countries that I've visited in West Africa, some of them don't even have any form of HPV program. But we have response from 5 countries from West Africa. And talking about the workforce, we have only 14% of those hospitals that responded actually have dedicated HPV trained surgeons. Anesthesiologists that have interest in HPV is just about 20%. It's more rare to even see a nurse talking about HPV in the part of the country where I practice. In the part of the world where I practice, about a quarter of the hospital have interventional radiologists. However, the amount of procedure they can offer is not as good as what you enjoy with some of your interventional radiologists. The majority of the interventional the radiologists that we have are general radiologists, and that affect the quality of imaging and the reporting that we receive. Looking at the infrastructure and the equipment that we have, of course, because of Ebola and COVID, the ICU situation is getting better. It's seen in about 87 of those institutions. But when you look at fractionized blood that may be necessary to rescue some of the procedure that you do in HPV, it's only about half of the institution that can provide that kind of service. We have a number of imaging. A CT scan is available in 80% of the case of the hospitals. MRI is available in about 60% of the hospitals, but only 20% of the hospital have intraoperative ultrasound. When we look at parenchyma dissection instrument and other instruments that are needed for HPV surgery, ligature is only found in a quarter of those hospitals, and ditto to vascular stapler, ultrasonic dissector, scalpel is very rare in our setting, and only 14% of those hospitals have liver retractors. Despite the lack of resources, of course, people still offer some HPB services. But like I said, majority of these procedures that are done, open cholecystectomy, laparoscopic cholecystectomy is beginning to gain weight. Half of those hospitals are doing laparoscopic cholecystectomy. Majority of those hospitals only perform bypass surgery. When you look like cancers like Klatskin's, tumors, none of the hospitals in West Africa performed surgery for such patients, and liver transplantation is completely zero. Major liver surgery is only done in 14% of all these hospitals. And when we look at the pancreas, 14% of those hospitals attempt Whipple operation. And of course, the number of support service to make pancreatic surgery safe, like ARCP, because majority of the patients present very late with deep and high bilirubin in their system. Only 5.7% of those hospitals have facility for ARCP. So why do we need ARCP in a setting like that I practice? One of the reasons is because majority of the patients present very late with obstructive jaundice, and they don't even do well to bypass surgery that is available. What we found, some of the authors, Nigerian authors, reported as high as 60% mortality following doing simple bypass surgery, because majority of, about 80% of them present with deranged transaminases. Alkaline phosphatase is in the roof for most of those patients. They're actually very sick. Majority of them have features suggestive of hepatorenal syndrome at presentation. So not only because of this, we need to support evolution of surgical evolution in Nigeria. Laparoscopy surgery is becoming a request. Most patients with open that have gallstone they've read in Google about that this can be done by keyhole surgery, and they are making requests for it. And that is driving the young surgeons to learn the act and want to do it. And of course, we know that as you build the learning curve, there are some issues that come along with this. And you need something like ERCP and interventional radiologists to be able to do this. To be able to make some of our patients surgically amenable, you need ERCP to help them. But more importantly, we know most of our patients present in advanced stage of the disease, and they will need some form of palliation. And that's why we feel that ERCP is a major backbone in building HPB surgery in a center where it is not existent up to now. I see that as a challenge, especially when I saw Dr. Blumgart that he pioneered ERCP. So probably I can do something similar in West Africa. I had the number of opportunity to train. And after the training, I tried to start the program. Of course, it wasn't that easy until I saw this angel, Dr. Akwi Asobang, that agreed to come to Nigeria to join us and start with some few cases. And of course, we started in March 2018. We start with an humble beginning. Of course, we use the CHAM that is being used by the orthopedic surgeons in the hospital. We started the program, we donated consumables, and this was actually self-funded by all of us because we have the passion to ensure that this is started. Within a short time, about 5-6 years that we started, we've done over 1,080 procedures in 886 individuals. And the number of cases that we are doing is increasing every year. We are able to do ERCP for pediatric patients that needs it, especially some of them with stone. Until recently, most of them will be operated, but now we can offer them this service and eventually have laparoscopic cholecystectomy for them. Even in 2024, the number of cases we've done by the end of March is more than what we've done in the first 2 years. Majority of the cases that were referred for ERCP, 2/3 of them are actually from malignancy, and that makes it quite challenging to build the program in Nigeria. What we see routinely, bile duct that is as big as 3 centimeters. I'm sure this is something that you rarely see in this environment. We see almost every week ampulla that is completely destroyed by tumor. You will be surprised that how do you put a stent in this? we have been able to build the skill because that's the kind of patient that we train with to be able to stand this kind of a patient. Our successes have been modest and probably comparable to what is obtained in this part of the world. For patient that doesn't have destroyed ampulla, our success is up to 95% and about 85% if we put all the patients together. We've been able to establish collaboration with vendors that donates, that we purchase consumables from directly. When we started, of course, we had some itches, and but our perioperative mortality is peri-procedural mortality is not bad. It's just about 1.2. We lost some patients to anesthetic complication, which was essentially around the time that we were starting the procedure because those patients were actually very sick. But now the anesthetists know what to do, and we are even taking more challenging cases now. We lost some patients to bleeding, one patient to severe pancreatitis, showing that ERCP is actually a dangerous procedure, and it should only be done by people that knows how to do it. ERCP actually changed our management of pancreatic cancer. Before the advent of ERCP, we only do about 1 or 2 in a year. Majority of them are actually accidental. In fact, the first Whipple operation that I did I came from a training from Egypt, and I was doing a bypass for a patient. And I told my resident that to do a Whipples, you need to be able to tunnel behind the pancreas. And that was what we were just teaching, just to teach them. And as I tried to tunnel, I discovered that, oh, the portal vein is not encased by this tumor. This patient should actually have Whipple operation, and that's how we did the first Whipple. The patient survived, though we started the procedure at 3 p.m. in the evening, and we finished around 10 p.m. Of course, I've been told not to do such kind of a thing, and we tried to plan our procedure appropriately. The number of Whipple operations that we do has increased lately, and we can now offer them chemotherapy to push the envelope of our resection further because we can take care of the jaundice that they present with. We've done about 48 cases so far. Majority of them were after the advent of ERCP. Perioperative mortality is still slightly high. I told my friend Peter that I've been shying away of publishing this because I want us to do more so that we can dilute this perioperative mortality. Most of those cases that died of the procedure were done when we were learning and trying to build the skill. And because we were operating patients that actually should not be touched. And eventually we lost some of them. But in the last few years, we rarely lose any patient following Whipple operation. And now, one thing I believe is that we need to quickly see how to push the envelope of our resectability to be able to accommodate more patients that have been presented, the kind of cases that have been presented in this type of conference. We've been successful, lucky to with some of with patients with distal pancreatic tumor. Very few of them were done laparoscopically. If you see the picture on the right, look at that big tumor. I'm able to see probably how many of us in the house will be able to take this thing out laparoscopically. By the time you take this tumor down and you want to remove the cancers, you'll be making incision that is as good as doing the procedure open. So, and that's the reason why we've not been able to build a laparoscopic skill for distal pancreatectomy in our environment. Majority of them survive. We rarely have any perioperative mortality with those patients. But when it comes to liver surgery, like I said, it's something that we've been told not to touch. So it was quite difficult to start a hepatobiliary surgery in my setting. We don't have dedicated liver retractor, no headlights. We only have basic surgical equipment. So, and most of us are afraid of bleeding. Well, after my training in MSKCC, with the collaboration of some of the colleagues that decide to follow us, we have donated self-retaining retractors. We have anesthesiologists were trained on how to do low CVP. And now I enjoy doing liver surgery than even Whipple operation, because if your anesthetists know what to do, the procedure is actually fun. And most of my residents these days, they are, is it being done? It is possible, because I always tell them that I'm not the one doing the surgery. It's actually the anesthesiologists that are actually doing the surgery for me. And if they know what they do, of course, you just enjoy and take the glory at the end of the day. When we started, of course, Dr. Kingham was with us. He was clean shaved then, but now you can see he has grown a number of beards. I always pull his leg that as the hair on my head is receding, is the hair on his beard is growing. So we are transferring it to each other one way or the other. The number of cases that we do has grown in the past few years. We do major HPV cases these days. And the number of ERCP that we do on the yearly basis has grown from less than 50 to close to 250. And sometime, in fact, this year, looking at the trajectory, we'll be hitting close to 350 at the end of the year. We have a team of nurses that are interested in the procedure, radiologists, gastroenterologists, anesthesiologists that have been trained. So we have a team around what we are doing, and that makes our life easy. But getting the appropriate patient is the challenge. This lady, I saw this lady last week before I left Nigeria, was sent to me for WIPO operation, for liver resection. Actually, you think it is that abdomen is full of water. No, it's not ascites. It's actually the liver that is this big. It's the liver that is that big, and that liver extended below the below the umbilicus. And that was the kind of case that we see. That's the kind of cases that we see. Majority of them are multifocal, making it difficult to be able to push liver resection further as much as we would have loved to do. But we have some treatment options that are available, resection though limited. We have some ablative therapy that are available, and we also offer them chemotherapy. This is a picture of a 26-year-old patient with ACC that had this in my hospital. In the recent time, we've done about 68 liver resection. Majority of them are for colorectal liver metastasis, but we've been able to do major liver resection on our own and in support of our collaborators. This is a picture of a 33-year-old lady with ACC from hepatitis B virus who had right hepatectomy. And this is the post-op period, and these patients have lived beyond 5 years. And now anytime she hears that somebody have HCC, she sends them to us directly. And she goes to the news to talk about her experience, that you can survive this disease even in Nigeria. Liver transplantation is not available. 2 countries have attempted it, and that is Ghana and Ivory Coast in support of some Egyptian doctors, but most of those patients, the 2 patients actually died. One died intraoperatively, the other one died less than 2 weeks after the procedure. So you can only access liver transplantation in Egypt and South Africa. Mostly are living related. The number of HPV cases requiring liver transplantation is so enormous in view of the number of cirrhosis from hepatitis B virus, hepatitis C virus that we see. And this is a great opportunity for collaboration. Please, we need your help. If you know how to start this, we are eager to start it yesterday. We see a number because of our ERCP program and because no other options are available in the country. About 50 cases of Klatskin tumors are referred to us on a yearly basis now. We've been reluctant to touch them. I'm hoping to get Dr. Janigin to Nigeria to come and show us how to do some of those resection. The only thing we offer them is ERCP, PTC, or PTBD. However, you know the kind of outcome you get from doing this procedure. Majority of them have recurrent cholangitis, and this is an excellent area that we are hoping that we can establish collaboration after this meeting. Whatever you are doing, if you really want to grow the program, you need a research, you need to grow the research aspect of it. So when we started, we established African Research Group for Oncology, which is a consortium from MSKCC and other North American countries, and over 32 academic institutions in Nigeria, and others are joining. Our focus is to build training, to do research, and also to improve the treatment outcome. We have a number of databases that are ongoing, gastric, breast, and other cancers that we've been able to establish. Some of them we have both clinical data and the tissue tissue bank to support the research. One of the database that we have is the colorectal cancer database, which was the first that we established. We have about 1,500 cases in that database, well annotated, and the patients are followed up. The median age of development of this cancer in Nigeria, not only colorectal, almost all cancers are about a decade or two younger than what is reported in most Western countries. About half of our patients actually present with metastatic disease at presentation. Because of this, only half of them are alive at the end of 1 year. So a majority of our research efforts is focusing on how do you get this patient early so as to be able to improve their quality of life and to be able to treat them appropriately, and also to push at treatment paradigm in Africa. So we've done a number of research, quite a number of them are funded. We've tried FIT, the fecal immunochemical testing, in asymptomatic patients, but what we found is that majority of the patients actually have false positive. And in a setting where the colonoscopy capacity is limited, that's not something that should be widely recommended in our setting. We've looked at a bundle of clinical symptoms and signs to be able to see if that can help to encourage people to quickly come early and have a treatment. And that seemed to be a little bit promising. And with that, we are looking at scaling this with a step-wedge randomized control trial, pragmatic trial that we are hoping to launch in the next few months. We've looked at everything. How can we diagnose colorectal cancer early? We looked at stool, we've looked at urine, and we were funded to develop a point of care using urine metabolite. And that we have a modest success. But our current effort is to look at blood methylation markers to be able to develop a point of care. This is funded by NIH, along with Memorial Sloan Kettering Cancer Center and Johns Hopkins University. Hopefully, we'll be able to provide data in the next few years. And if this is successful, I'm sure it's going to be a game changer in low middle income country. Our patient present late and very young, as I've said. Because we have a well-annotated tissue bank, we've been able to look at the molecular biology of colorectal cancer in our environment. One thing that jumped at us very quickly was that the MSI high rates in our environment is about twice or 3 times of what has been reported in most Western countries. And when we look at the sporadic colorectal cancer, WNT pathway is the common pathway that has been said for the development of sporadic colorectal cancer. And when we look at that pathway in our cohort, it seems not to be the dominant pathway that is being activated in the occurrence of colorectal cancer, showing that probably most of the tumor we are treating, they are actually unique. And we will have to look for the best way to treat our patient rather than adopting guidelines that are thrown at us from Western country. This slide is very unique because when you have high MSI rates, what you are thinking is that majority of them are actually sporadic. Probably they have double mutation. And what you use to separate those that are germline, that have germline mutation from those that have sporadic is to do a BRAF mutation. When we look at the cohort of our patients that have BRAF mutation, you can see only none of them actually have BRAF mutation, meaning that most of the high MSI rates that we have are actually germline mismatch repair deficiency. And that's why we are developing, and we'll be starting the first African immunotherapy trial, which we hope to start in the next few months. We've gotten almost all the paper ready to be able to prove the concept and to be able to see how we can deploy this very highly sensitive agent in a setting where majority of our patients die. This is the schema that we are hopeful to use. I'm very conscious of time. I think I have just 2 slides. The first is that I have a dream, like it has been said. And the dream is that before I retired, we have a dedicated HPV training fellowship in West Africa, that will be able to train people to treat these treat these cancers locally. In collaboration with, it's not far-fetched. That dream is not too far-fetched, because in collaboration with Queen's University Memorial Sloan Kettering Cancer Center and SSO, we are starting the Surgical Oncology Fellowship, first time in West Africa this year. So if we can achieve that, I believe we can also do the same thing with AHPBA. This is a must if we want to improve the outcome of or some of those cancers that are seen in my part of the world. Let me conclude by saying that by adding some of the initiatives that have been currently being deployed by IHPBA, and that's the HP Bridge initiative. This is a bi-directional initiative from established centers and emerging centers. 6 group was established. Our group is number 4. We have a partner from US, from France, and from Israel. And a number of hospitals have signed into this from Nigeria. Our desire is to continue to review cases on every month and see how you can train the radiologists, benefit from both sides, and see how you can improve the quality of care that is currently being offered. I believe that we need to look for more of such opportunity to be able to improve the outcome of management of HPV cancers in West Africa. Leslie Blumgart is still alive. I can tell you confidently, though he may be dead about a few years ago, his legacy and his desire, his dream to transfer knowledge is still much alive. The passion for education and the expansion of HPV care globally is probably we are the late to catch it up after he's dead, but at least we are catching it up because that's some of the desire before he died. His philosophy lived through the MSKCC efforts supporting us in developing HPV program. Potentially, I believe that in West Africa, we can have probably one of the largest HPV in Africa due to the amount of collaboration and training that we are receiving and because of the volume of cases that we have. I can't round up without thanking some of those people that have made this journey very nice for me. Sam Murray Brenner was the one that invited me for the Sodava Fellowship that gave me the opportunity to meet with Dr. Blumgart. My friend, Dr. Peter Kingham, he's visited Nigeria almost about 3 to 4 times every year in support of our research program. And he's able to do this because all the leadership in MSKCC has been very supportive. We've been largely funded by NIH and some philanthropic body. Of course, I'm deeply grateful to IHPBA that brought out that initiative that is helping us to develop HPV Bridge. I received some help while preparing my thought for this slide. Dr. Shisha was very helpful and Dr. Kingham was very helpful. Thank you. Please feel free to reach out to us if you have any idea by which we can build HPV in West Africa. It's a must. We need to close the gap. Thank you.
Isaac, thank you. That was a very inspirational talk. We have time for a couple of questions from the audience. Dr. Peter Allen.
Hi, Isaac. It's great to see you and to hear you. I have 2 quick questions for you. Number 1, have you checked the MSI high status on your HPV tumors? Because if this is germline, you might find that Pembro will be helpful for your HPV cancers as much as your colon cancers. And then number 2, I just wanted the 60% rate of mortality in the setting of jaundice is obviously quite high. And I get all of the differences in approach, but I'm wondering about the cause for it and if renal failure is a significant cause, because maybe the anesthesiologist, with the use of more fluid, admitting patients pre-op with fluid may help with that situation. Thank you.
Yeah, definitely. Of course, we are trying everything to make the procedure better in our environment. and everything that has been reported in literature is being thrown at this. And we are looking, hopefully in the next few years, we'll be able to tell people how to deal with these kind of cases that we manage in this part of the world. Probably other parts of the world will learn from our knowledge. MSI in HPV cancers is something that we have in view. We are building both local and international collaborators to be able to do this. And hopefully in the next few years, we'll be able to provide this kind of answers.
One more question.
Thank you so much, Professor Olatashe, for such an invigorating talk and for educating us about your experience really building this incredible program. I've had the pleasure to work with you personally, and one of the things that really strikes me, you sort of showed in your slide over 1,000 ERCP cases as the only person performing this operation in a country of 200 million people. Can you speak to sort of your experiences from the perspective of the implications for surgical education? As you know, many of us finishing our residencies and fellowships here are not trained in ERCP. Can you just really comment on what the future you see of West African surgeons being trained in advanced endoscopy? And then the second question was, I know you are also very passionate about endoscopic ultrasound, and that's something that you're looking to start in the country, and we are yet to start. But maybe comment on where you think an organization like AHPBA can help support some of those efforts. Thank you.
Thank you for those questions. They are beautiful questions. The first on surgical residency or surgical fellowship program in the part of the world. It's not only if you want to train in HPB in West Africa, you are not only going to learn endoscopy, you have to learn so many things because there's limited workforce. You have very few oncologists that are going to support. So the way we are building our surgical oncology program is to ensure that the resident or the training fellows are exposed to as much things that will help them to build the program, get a number of exposure in how to give chemotherapy to those patients, a number of exposure in how to do interventional radiological procedure, basic one that you can offer to the patient in case you're lucky to not to have one around you. You have to have exposure in interventional endoscopy program. And that's how we have developed our program. Of course, many of us on this part of the world are spoiled because you have so many people doing things with you and for you, and they are just a phone call away. Unfortunately, we don't have that luxury in West Africa. So a number of skill sets has to be developed. And that's why I'm an oncologist, I'm a surgeon, I'm a endoscopist, I'm an interventional radiologist. But building the skill, we are building the trade. So quite a number of young ones are being motivated to join us. And hopefully very soon I will leave some of those things and I can focus on one area and that will be a good time to retire from this. Endoscopic ultrasound is an important aspect that needed to be developed in West Africa. Like I said, the reason why we don't have a database is because we can't take biopsy for most of those patients. And it's because we don't have endoscopic ultrasound. If it's something that I can grab along with me to Nigeria, that's something I believe we need to do. We need to build that capacity in West Africa so that we can put a name to disease. There was a meeting I attended and I was talking about cholangiocarcinoma. And one of the very senior persons said there is nothing like that. All obstructive jaundice are from CA head of pancreas. But of course, he came back to tell me that it seems as if you are true. I'm beginning to see even more cholangiocarcinoma than CA head of pancreas. I told him the reason is because you aren't looking. You don't have people that can help you to look into this and find out what's the cause of this obstructive jaundice that this patient have. I believe that's the kind of setting Dr. Blumgart found himself, and that's how he has to build that skill to be able to put a name to the cause of obstructive jaundice that they see at that time. Hopefully, we'll be able to do that. We can build that skill in our environment, and we can tell the world the kind of cases, HPV cases that we see the most common, and how do we treat them. Thank you.
Fine.